Hey, good morning, and welcome to the McGill Dementia Education Program's Caring Conversations, a free community outreach initiative to provide virtual support to care partners of people living with dementia. The McGill Dementia Education Program offers a comprehensive range of free resources to educate and support people living with dementia, families and informal care partners, healthcare professionals, medical students, and the public at large. An important resource is Dementia, Your Companion Guide, which is available online for free in 10 different languages. Printed copies can also be obtained at Amazon. You can also find answers to many of your questions in the extensive library of McGill Cares webcasts and podcasts. Caring Conversations is an initiative of the McGill Dementia Education Program and is supported by the Petro-Canada Caremakers Foundation. So today we're going to hear from Lucy Barylak and Joanne Besner. Lucy Barylak received her Master of Social Work from the McGill University School of Social Work. She's developed evidence-based training for seniors and caregivers, and she's lectured in the field of social gerontology and presented at major conferences. Her research studies have been published in numerous journals. Ms. Barylak received the Queen's Jubilee Award for her role in developing a national coalition to support caregivers across Canada. Joanne Besner is an educator, professional coach, and caregiver. She received her Bachelor of Social Work and Master of Business Administration from McGill University. Her 35-year in public community healthcare in Quebec spans many roles, including frontline case manager, clinical supervisor, manager, researcher, and trainer. Today's topic is dementia and inappropriate sexual behavior. A big challenge that caregivers might face is managing inappropriate sexual behavior exhibited by a person with dementia. Lucy and Joanne will discuss the feelings this can cause and provide some tips for dealing with it. We ask that you please keep your microphones muted, and we will unmute people as needed once we open the discussion. We also want to let you know that this webinar is being recorded and will be posted on our website. We'll stop recording about 15 to 30 minutes before the end of the session, so that anyone who might want to share but doesn't want to be recorded may have a chance to be so. So thank you very much, and please go ahead, Lucy and Joanne.
Good morning, everyone. Thank you, Diane, for introducing us. So for some people, our topic is a very difficult one to discuss. It touches on our values, our culture, religion, and how we ourselves feel about sexuality, especially as we age, and particularly when the person we care for has dementia. How do caregivers deal with the issues around sexuality? In my work experience, many caregivers shared feeling embarrassed and very much alone. And not just the caregivers, even professionals may be uncomfortable and ill-equipped to tackle this issue, which is why it's so important to have the education and information in order to increase our comfort levels. And that's why we've brought this topic today. So we're going to start with a couple of letters that my colleague, Dear Lucy, received from some caregivers. And maybe you can relate to their questions as well. Dear Lucy, my parents are both in their 80s and live on their own. My father has dementia and my mother is his full-time caregiver. Two of my siblings are out of town. I visit my parents a few times a week, shop, and do the laundry for them. My father and I have always had a very close relationship, and he used to call me his princess. Lately, I find him to be more forgetful and not himself. My last visit was very dramatic for me. I was helping my dad out of his chair when he stood up, he grabbed me and started to kiss me, but not like his daughter. I was so taken aback that I left as soon as possible and I never told my mother what took place. What should I do? Did I do something wrong? And our second letter. Hello, I'm not sure how to start. My wife and I decided to have my mother live with us after she was diagnosed with Alzheimer's. She has been living with us for the past 2 years, and my children really like having her here. The problem is that a few months ago, she started taking off her clothes at different times of the day and became very agitated when she is told not to. This is so embarrassing to me, especially when the kids are around and they start laughing. What is going on? I have no one to talk to. So what can caregivers do when the person with dementia is sexually inappropriate? So what we're going to cover today is the following. We're going to open with just a little bit about sexuality and intimacy in general. And then what is inappropriate sexual behavior in dementia? Why does it happen and what could trigger it? And of course, we always end with tips. So we will today as well. So sexuality touches, as I said it before, on our belief system. Sexuality and intimacy are a fundamental part of human existence. But societies also impose restrictions or norms on what's appropriate or acceptable when we express ourselves, which differ for different age groups as well. Despite the prejudices and cultural bias, research evidence shows that sexual interest and regular sexual activity frequently continue well into the 70s and 80s and beyond. Because the need for close contact does not decline with age or dementia. And in fact, maintaining sexual expression is an important indicator of well-being in older people, physically, emotionally, and cognitively, and for everyone. How we feel about sex, especially as we age, will determine our response to these challenges. Keep in mind that those with dementia often communicate with behaviors rather than speech because they are unable to, so they can be misunderstood. So what does inappropriate sexual behavior look like, or what could it look like? So we have some examples: masturbating or fondling genitals, sexual language and explicit commands, taking off one's clothes or exposing oneself in public, and non-consensual sexual advances towards others, touching or grabbing. These are just a few. And if you have any examples, as always, please feel free to add it in the chat to participate, and we'll be happy to come back to you later with any questions you have. But when we talk about this topic, we have to be very careful about defining what inappropriate sexual behavior really is, because it depends so much on the context and it depends on our values. So some questions we can ask, because when things happen, we can, as our person in our first letter mentioned, we can become so taken aback. It can be very dramatic for us. So it helps to think about the following. What form does the behavior take? And what's the context? How frequent is it? Is this a one-time thing, or is this really happening as a pattern? And what's contributing to this? Is it a problem? And if it's a problem, who is it a problem for? Is it a problem for them? Is it a problem for you? Is it a problem for someone around? What are the risks involved, and to whom? And of course, we always look at, are the participants around competent? So what causes sexually inappropriate behavior in dementia? And we want to remember, first and foremost, it's caused by damage to the brain. This is not a deficiency in the person's personality. Dementia affects the part of the brain that controls one's ability to control our responses. So it's our impulse control. So inappropriate sexual behaviors can reflect an unmet need, and that's why it's often misunderstood. Remember, someone with dementia, sensory perceptions can be affected. This means what they're seeing, their eyesight, what they're hearing, smell, touch. So it's not uncommon to not recognize their caregiver. They may mistake a daughter for their wife. If this happens, try not to scold them or embarrass them. Remind them who you are. For example, it's me, Daddy, your daughter, Joanne. So we wanted to give you a few statistics because you might be wondering, well, how often does this happen? Maybe it's happening to you. Is it happening to other people? And who is affected? And I want to say in the search for statistics, it was particularly challenging around this topic. Statistics are limited and you can understand maybe under-researched. So what we were able to find are the following. Around 7 to 25% of men and women with dementia may exhibit ISB, is a shortened version for inappropriate sexual behavior. So 7 to 25%, approximately 60% of these incidences are verbal comments. And the frequency happens to be less in those with Alzheimer's type, more 7 to 8%, and higher in other types, with the highest being for those who present with vascular dementia. So it depends on the areas of the brains affected, and we know damage to the frontal and temporal lobes is associated with difficult behaviors. So if you are having that kind of a dementia, it's likely to decrease inhibition. Excuse me for a second. 5 to 20% of persons with dementia exhibit some degree of inappropriate sexual behavior at some point during the course of their illness. And interestingly, more common, it's found in group living situations. So that brings us to mention a word on care residences. So you can imagine that we've been talking about the perceptions of inappropriate behavior between individuals and what it's influenced by. And all of a sudden, you're in a group setting with many people with varying perceptions and attitudes. So the effect of sexual behavior on others is particularly relevant in a nursing home or residential setting, and where there's very little privacy and there's very many differing attitudes towards sexuality. So tolerance around things like language, implied sexual innuendos, even making jokes about it, touching, hugging, and other acts. You're dealing with a lot of differences versus being in your own home. So it's important to also mention that living in a residential, nursing, or shared home does not mean that people cannot continue to have sexual relationships and be intimate if they want. If your partner is living in a residential care or moves to one, talk to the social worker about your need for private time with your partner, especially if they are in a shared room. And of course, this brings us to safety and protection. What might happen if a resident shows affection or sexual feelings or inappropriate sexual behavior towards another resident or staff member? How does the residence protect vulnerable residents who may not be capable of consenting? What is the home's view on consent and capacity? If a person does start a new relationship while in a residence, there may be concerns that they are being exploited or taken advantage of, or somebody else is. But as long as the person with dementia has the mental capacity, the ability to make these decisions and consent to the relationship and wants to pursue it, then the relationship should be respected. But this is very easy to say. And we know that evaluating this is very complex ethically and medically. So if there's a concern, we have to talk about it and we have to bring it up. And the two main questions we want to be thinking about is the person who's exhibiting inappropriate behaviors, are they receiving the proper intervention by trained staff? And in new relationships in long-term care, is the person with dementia being taken advantage of? So if there's any concern about welfare or safety, it's important really to bring it up to the home and to a healthcare professional. Again, I hope you'll be adding your comments or your questions in the share chat. because again, reminding you this is Caring Conversations, and we hope to really have a great discussion after our presentation. So why it's important to share. Don't keep this to yourself. Lucy and I always say you don't have to go through this alone. It's important to explain inappropriate sexual behaviors, whether your person is living at home or in a care residence. Talk to family members, friends, and people that you trust. Explain it. They need to know that the behaviors are caused by damage in the brain from the disease and not the person. They need the information and education just like we are talking about it today. If they don't understand, they may not want to visit, or they might get angry with the person or feel embarrassed for you. And there's another really good reason to share. It takes energy to hold back secrets and hide things. And this energy depletes you as a caregiver and can cause you even more stress. So actually sharing, even if it's uncomfortable, can be therapeutic to you and can help you process and can sometimes feel like a big weight off your shoulders. So here I am going to pass you to my colleague, Lucy Barylak, and she is going to get into the nitty-gritty about what causes it and what you can do about it.
Thank you so much, Joanne. Yes, it is very important to share what you're going through. You know, throughout my career, caregivers have reported how difficult it is to deal with sexual inappropriate behavior. You know, so many feelings come up, and one of them is how not to take it personally, and that's not easy to do. I have to say that there's no magic formula on how you should respond to this behavior, since every care receiver is different, and therefore you will have to experiment with different tips that we want to share with you today that works for the person that you are caring for. Excuse me. One of them is really to try and identify the triggers that may cause the behavior. As Joanne said, because of the damage to their brain, they are not able to tell you what is actually bothering them. Rather, they act out in behaviors that may be inappropriate and difficult to manage. And it's not just sexual difficult behaviors. It could be any behaviors. And I think these tips are really good to kind of look at that. There is a way that can be a great help to you and the person that you're caring for, is to really try to identify the triggers that may cause the behavior. And there are a lot more, but we're just going to focus on a few. And if you could identify some others, we'd love to hear from you. The person actually could just be bored. They could be cold, they could be hot, they could be in pain, they could have an infection, or other medical problems you're not aware of. For example, maybe they were put on new medications that is kind of triggering this behavior. And believe it or not, it could also be over-the-counter medications that you might be giving them that triggers that behavior. Excuse me. They may need to go to the bathroom. They could be tired. They could be hungry. They could be more confused. What I want to tell you is if you notice this kind of behavior and it's starting, make an appointment with their doctor as soon as possible. Please write everything down that you're noticing and tell the doctor as well. If the person you are caring for is making unwelcome sexual overtures towards you or others, the doctor needs to know. Don't be embarrassed to talk about it. There are medications that could calm the person down. You know, the doctor and you should make those decisions together because there are side effects to all medications. And maybe by calming them down a little bit, they might be a little bit more disoriented. These are the decisions you need to talk about. When you go to the doctor, please make sure to bring all the medications that the person is on, as well all the over-the-counter medications that you might be giving them, including vitamins or herbal, everything. The doctor should go over all the medications and decide whether to increase or decrease. Now, another good tip that's really quite useful is to use a journal to keep track. So why am I saying that? It's important to know what happens right before. What happened here? Is it happening repeatedly? Which factors are always present before the situation occurs? So, for example, everything was going well, and all of a sudden they start becoming agitated. But you've noticed that when this happens, they actually stand up and they start pacing back and forth. And you need to ask yourself, does it happen at certain times of the day? That's a really good clue. Also, look at the environment. Is the temperature of the room, is it cold? Is it too hot? What is the noise level? You might have turned on the TV or radio, and all of a sudden their behavior has changed. They might be frightened. Once you recognize some of these triggers, it may be easier to avoid them and actually control them. So, for example, if you notice that at 3 o'clock in the afternoon, there's a pattern there, you've kept track of that. At 3 o'clock, they start becoming restless. So at that point, you kind of, you know. And so what could you do there? You might ask them if they need to go to the bathroom, or you might ask them if they would like a snack. So this is one way of trying to deal with it, but there are a few more that I'd like to talk to you about. So here are 3 tips that you can try to de-escalate a difficult behavior and hopefully engage with your family member in an interaction that is positive for both of you. The 3 words I'd like you to keep in mind are deflect, distract, and redirect. These 3 interventions don't need to be done in order. Try one at a time and see what happens. So what I mean by deflect, so you're noticing all of a sudden that the person you're caring for, they're becoming agitated, they're trying to, come in closer, they're behaving in a way that they weren't a few minutes before. So deflecting means you're trying to get their attention, okay? So one way to do that is call out their name, call them by name. Look into their eyes, possibly hold their hands, change the subject, ask them a question, or turn on the TV. Sometimes this little intervention really works. Now, there's another one that could work as well, and you could try it. You can distract them. What I mean by that is that you can take them to another room, offer them a cup of coffee, a snack, whatever it is. Take them to the bathroom, see if they need to go. And one caregiver told me that this really works for her. What she does is she takes her husband to the window and they look out the window and they count how many cars go by, and somehow this sort of calms him down. Now, once you have their attention and it's kind of working, I think it's so important to do an activity with them. An activity that you're both doing together. It could be because in that way, you're also distracting them and you're also deflating. Reminiscing is great. I'm sure you all know that. You might not remember what you did 5 minutes ago, but many of them can remember from the past. Watching TV, if there's a show they like. Music is amazing. Music really, really calms people down. Singing along. If it's a nice day, go for a walk. Using laughter as a means of redirecting is great, especially if that person always had a kind of good sense of humor, can tell them a funny joke, whatever it is. But another really good tip is to make sure you have activities close by and ready to use in case you need them, like really, you need them right now. You can have them in a drawer, it could be in a box. You can put pictures in them, photo albums of vacations. You could put on a movie. Music again is great. I remember one caregiver telling me that once she put the music on, they would dance together. Have paper and crayons handy. Simple puzzles are really good. A ball is a great activity. You can pass it back and forth. Balloons are a lot of fun. A cuddly soft toy. By being prepared, you may be able to control the situation a little better and actually have a nice interaction with that person. That's, in a way, not a caregiving task that you're doing. You're connecting with them. You're having a good time. Now, caregivers tell me that this really works. So I hope that you try that as well. At the same time that you're trying to deflect, distract, and redirect, always stay calm and patient, okay? Now, if deflecting, distracting, and redirecting isn't working, please stay calm and be patient. Gently and firmly tell the person that the behavior is inappropriate in your own way. But you should match your body language to your words. Think of your tone, your voice, and your facial expression. Don't look angry, look kind of kind. They will respond to your body language better than to your words. But it's also important to maintain consistent, firm boundaries. Don't accidentally encourage inappropriate behavior by sending mixed messages. Even though we know, as Joanne was saying, it's so important to have physical contact, and that's okay. You can hug, you can hold hands. But if the person all of a sudden starts grabbing at you or starts getting angry at you, I think it's important that you could say, no, stop, I don't like that. Or stop, that's not right, and shake your head. Now, it is so important not to shame the person and to keep remembering that they are not in control of their behavior. Please don't argue with them. It won't help. It can only escalate the situation. Watch for nonverbal cues from them. As I said before, you might recognize, maybe they do need to go to the bathroom. Let me try that. Let me offer them a snack. Show empathy. Remember, it's the disease that is affecting their behavior. And again, don't take it personally. Easier said than done. But you got to kind of remind yourself. This takes patience and practice. So please, don't give up. Now, if your family member takes off their clothes, touches themselves, or masturbates in front of others, this often is a sign that they are uncomfortable. It's not a sign that they want sex. It's often a sign that they are uncomfortable or need to use the bathroom, or that they were used to walking naked at home, and it's only a problem now that they are around other people. And that goes as well for masturbation. So let's look at some of the other practical tips that could be helped. So again, I want to say that most of these tips are all from caregivers that actually helped them and shared with us. Now, suspenders and overalls may be a better choice when someone is trying to take their clothes off. This one I absolutely love, okay? Wearing an apron with pockets filled with interesting objects to keep their hands occupied. Not just for just their hands, but in general, it does work. And it's really good for men and for women. You can put a small ball, you can put soft fabric that people like to touch. Pictures are great, costume jewelry, and for whatever reason, coins, men seem to like to play with coins. So, the other thing is if they become restless, try to put a pillow on their lap to hold or hug. And even a nice stuffy kind of animal works as well. If they're restless in bed, a body pillow to cuddle could be helpful. You can get that on the internet. And when in public, bring a shawl to cover them if they really start removing their clothes. Or, as I said before, distract them. If you see that something is really brewing, take them somewhere else or say, let's go and have a cup of coffee. It's always good to have a shawl anyways, in case you're cold. Now, some people with dementia symptoms can display aggressive mood disorders due to increased libido, loss of inhibition, and judgment. Now, your loved one may display difficult and dangerous behaviors, okay, both physically, verbally, and sexually. Now, many caregivers in the past would tell me, Lucy, it only happened once. It was an accident. He's such an amazing, wonderful man. Believe me, from my own experience, if they do it once, they will do it again. The person is not the person that you knew before. and you have to protect yourself, and you have to protect them. You should never give in to sexual demands if you don't want to. This is sexual abuse, and it's really unacceptable. It's really hard to accept, but that's the reality. They may get angry. They may hit, they may punch, they may curse or scream. Please don't argue with them. Move away from them and put a plan in place. So what do I mean by putting a plan in place? There are some family members that you could speak to, as Joanne said, and friends that you trust. Tell them exactly what's going on and ask them if it would be okay for you to call them when you're in a difficult situation, and would they be willing to come over once you call them. So you might have one or two people on the list, and hopefully one of them will be there for you. So in that case, if the situation seems to be escalating and you're kind of, your gut tells you that you're afraid, call a family member and hopefully they'll come over. But if the behavior escalates and you can't control it, you're going to have to call 911. It's not an easy thing to do, but in a way, it's the right thing to do because you're going to protect yourself and you're protecting them. This may be a wake-up call regarding your future caregiving role and what is best for you and the person that you're caring for. I would like to share with you an incident that happened when I worked at a CLSC in a home care department. I got a referral. It was a couple. They were both 80 in their 80s. The husband was diagnosed with dementia, and the wife was the caregiver for her husband. And all that she was asking was for a bath assistance or a shower. So I went and I did a home visit. It was a really nice little condo that they owned. Everything looked really well. She showed me around. We went into the bathroom and I said, well, I'd like to, if with your permission, make a referral for an occupational therapist to come and assess the safety of the bathroom. She was really very happy with that. We then went in. I asked her lots of questions about her history, being a caregiver. Is it difficult for you? All the chores that she was doing. I also asked about her medical condition. Was she able to get out of the house? Does she have, not isolating herself? I also asked about the husband. What was his medical problems? All the things that were going on. And I said, is there anything else you need? And she basically said, no, everything is fine. Okay. So I said, all right. I was really pleased. It was a really easy case. I started walking to the door, and as I'm opening the doors, I see her coming towards me, and she's gesturing to me that she wants to tell me something in my ear. So I listened. This is exactly what she told me. He's trying to rape me every night. I can't take it anymore, and I'm in pain, and please help me. I have to tell you that I was shocked. But at the same time, I was happy that I was able to connect with her, that she trusted me enough. And not only that she came to the point where she actually needed help and asked for help. So I just want to tell everybody, we all need help at certain times in our lives. And I think it's so important that you don't need to do this alone. And there is help out there. There is family and friends that could be of great support to you. When Joanne talked about not keeping secrets, people that are there that care for you. There are resources in the communities. Every community has a CLSC. Call, try and speak to a social worker. You might, you may want to have individual counseling. That's okay. There are support groups, and there are sessions such as we're doing today, an opportunity for you to have the ability to share some of your concerns. Now, there are support groups, and they're great, because what support groups really do is that you feel that you're not alone. You're not the only one going through this, that other people go through this alone as well. And that, in many cases there is a light at the end of the tunnel. So I guess what I want to do right now is I want to turn to you, our audience, and let's have a caring conversation. Please share with us, ask any questions, make comments. Joanne and I are here for you.
So it's Diane here. I do have a couple of comments and questions from the chat that I'd like to share with you. So going back to the beginning of your presentation, ladies. So one of our guests mentioned that the behavior that was described in your example seems to be more about losing one's inhibitions rather than being intrinsically sexual. But I suspect a loss of inhibitions marks the beginning of a change in behavior that could lead to inappropriate sexual behavior.
Yes, and I think exactly. Very well said from our participant. And as we did mention, it depends on the parts of the brain impacted. So we see that it's a loss of impulse control. And that's why, again, we have to say these behaviors, when we say sexually inappropriate, are less about sexuality and more about how the brain is functioning.
Yes. And to keep in mind also, when I was saying that, some things are just normal for some people to behave a certain way. I mean, people masturbate, and it's okay in their own privacy. It becomes an issue if it's done in front of other people. The same way as removing clothes, Many times people feel very comfortable in their homes, either walking around naked or just wearing a pair of shorts. And very much what Joanne also said in that letter in the beginning, the daughter, taking into consideration their sensory. I don't know if that father in particular maybe didn't recognize his daughter. I assume that he did not recognize her, or he wouldn't have behaved in such a way. So all these things really, really need to be looked at.
Thank you. And just to mention that the same person who posted that comment also wanted to say thank you both for having these presentations and conversations. You've helped me greatly and my family to navigate the various stages of our mother's dementia. Thank you.
Okay.
Thanks for sharing that comment. So I do have another comment as well. So this is when you were talking about your strategies, deflecting, redirecting, and distracting. So would these be more avoidance coping strategies instead of facing the basic needs that need to be satisfied somehow?
Well, I think it's like you get a sense, like if things are going okay, I mean, it's fine. You have your daily routine, your whatever it is that you're doing. But if all of a sudden their behavior changes for whatever reason that you're not aware of, and when I talk about behavior changes, I'm not saying like they could be, not talking about them being moody. They're allowed to be moody, or they're, not as possibly talkative. I'm talking about behaviors that are difficult to manage. They might start yelling. They might start pacing up and down. They appear scared. They're grabbing onto you. Behaviors like that. So these tips really work, because what you really are trying to do is get them out of that situation at that particular time. And arguing with them or telling them, stop it, stop this behavior, being ridiculous, is not going to work. So these tips are by trying to connect with them, by looking at them into their eyes, either holding their hand, getting their attention, moving them away from where they are to another room, can just like that change that behavior. That's what you're trying to accomplish.
I love what you said, Lucy, about also using a journal, because, and thank you for this question about avoiding versus or along with, addressing what's really the unmet need. Because the truth is, we can't always figure it out. What makes this disease so challenging is that inability to communicate. So Journaling is something that's used a lot of interventions with difficult behaviors to avoid going to pharmacology, going to medications. Why? Because because we can't understand the communication, we need to understand the patterns and the clues. And think about it, it's so hard just to think and figure it out. So sometimes writing down facts also and having it down on paper, looking back on it and comparing can really help you identify a pattern. Excuse me, identify a pattern and help you figure it out so that if you can figure it out, then you can deal with, what you figured out, an unmet need. And if you can't figure it out, then yes, avoidance or deterring or changing the situation, that's an option just to try and make it better really for both of you.
You're so right, Joanne. I was a caregiver for my mother for over 10 years. And by journaling, by really keeping track, I recognized certain patterns in her of what was the need at that particular time. And for her, it was she would go into another language, okay, her mother tongue. And I kind of figured it out, I don't know how, that she needed to go to the bathroom. I tried it and it worked. So, and and the time frame also, it seemed that certain times of the day, and we know that sundowning for many caregivers is a difficult time, but we figured out that there was a certain time in the afternoon where that restlessness that happened. So it was a great help. So yeah, you're absolutely right. It is important and useful.
So Lucy, we have a question in the chat for you. How did you help the wife whose husband was sexually assaulting her every night?
Oh, I knew somebody's going to ask me that, and that's okay. I mean, the first thing, as I said to her, I said, as I said, I was shocked. I didn't leave. Okay. I went back into the house. At that time, she was able to have some privacy with me. The husband went to have a little nap, and I tried to get a little bit more information from her. I thanked her for telling me. And once I got a little bit more information, I told her that the first thing she needed to do is to call the doctor, because it's important to know if it's a behavior that's new or kept repeating itself. And the way she explained it to me, it was going on for a little while, but it was new in a way because it never was before. So an appointment was made for the doctor. I did also say to her that she had a choice. Maybe we could get a respite bed for a little while so that he can go in for respite. In those days, I'm talking about many, many years ago, there were those opportunities, and I think they still do exist. He was put, yeah, so Joanne says yes. I didn't leave her in that house that day. It was an emergency, I felt, and I really had to advocate very hard. It's not easy sometimes to get a respite bed. But under the circumstances, it was either that or taking him to emergency because she was in pain, she was hurt, and she had to be taken care of. So he was placed in a respite bed for more than a week. The decision was made. He was put on medications, but with the family support, they did have children. Which was hard for them. She had to actually be honest with them because she never shared it. They were shocked because they didn't see their father that way. So I had to work with the family and explain very much what I did with our presentation today, what Joanne was doing, that it wasn't his fault, that it was the disease, and that, it took some time, but he didn't come back home. He was placed just for safety reasons for her. It did take a while. She felt extremely guilty, I have to say, because they had a very loving and caring relationship. He was always an extremely good husband and father. She could just imagine the turmoil that went on in this family with his own children, accepting and understanding what the father was going through, and feeling so bad that the mom didn't come to them, especially the daughter. There was a son as well. And, but that's what it is. It's generational. Remember when Joanne was talking about, even in today's society, this was many years ago, we look about, it's ageism in a way, older people don't have sex, but they do. And many people have very, very fulfilling sexual relationships. And not everybody with dementia behaves this way. So I don't want to scare anyone. So that's what happened with this lady. I worked with them for a long time. Family went into family counseling, not with me. It was a private counselor, psychologist that they went to. But it's so important to ask the right questions. About intimacy, what's going on about that, especially when someone has dementia, right? And I believe that it is part of the assessment plans many times, and maybe Joanne can elaborate a little bit about that. So it's important for healthcare workers to feel comfortable themselves about being able to ask these questions. So I think we do have them in our assessments, Joanne.
No, Lucy, I promise you're reading my mind, because this is exactly what I wanted to comment on.
That's why we're dear Lucy.
Yeah, so it's interesting because we were talking and reminiscing, and these were in the earlier years, Lucy, I believe, when you were, a pretty new social worker.
Yes.
And I'm glad you brought up this, and I hope if there are professionals, you could join our conversation. I really appreciate your honesty about saying, I was shocked, because we assume that professionals, because they're in this role and they're coming to our homes and they're assessing, that they're comfortable and educated with every topic. But in this area, they are not necessarily. And even if they are, professionals can feel uncomfortable too. It's so important not to avoid this issue. In the regular assessment forms, there is a section on sexuality. And I remember in my practice, when I would verify with my staff, are you asking the question? Because we feel it's underreported. Many of them would say, I'm coming into somebody's home. I barely know them. And 10 minutes in, I'm supposed to ask about sexuality. I'm not comfortable. And I don't think they would be comfortable talking to me. And it's very valid. Before you can share these things, there needs to be a connection, some trust. So there are ways to bring up this issue, and professionals can just ask about general intimacy. Are you close? How do you show physical love for each other? Do you hold hands? Is this an issue for you? So there's a lot of important training around this topic, because difficult behaviors is usually the tipping point where caregivers often say, like your client did, Lucy, I can't take it anymore. It's the tipping point where it's hard to stay home. And if you, of those behaviors, when you're talking about sexual behaviors, you have that added discomfort and all the societal norms that we have. So it makes it even tougher. It's so important to talk about. And we have to make sure we have educated professionals around us to give the space, to give an area like this where it's okay to talk about it. Even if we're not so comfortable, maybe you just listen to other people talking about it. But it's so, so important. And there's nothing to be embarrassed about saying, I don't feel so comfortable, or I don't have enough knowledge.
Yes.
Thank you. We do have another question relating to inappropriate behavior. So how can we avoid being too moralistic instead of staying strictly clinical?
That's a great question. And I'm wondering if that's from a professional. I would love to hear from you. It's a big concern. Even using the word inappropriate behavior, although it is in the clinical setting, it's used, that abbreviation, ISB, inappropriate sexual behavior, is used. But that's why I added the slide. We have to be really careful. It's such a judgment. It is a judgment. You know, what's appropriate for one may not be for another. Some people, you know, walk around naked and are very comfortable with sexuality all their life, and you've brought up in that context. Well, why wouldn't that continue in your later years? But then what happens if you're in a residence with other people? Or what happens when the grandchildren are around? So yes, I agree with you. It's moralistic. It's a judgmental label, and I would welcome better words. I think words are very, very important, and we just have to recognize we're using them to communicate. But thank you for that. It's definitely a judgment and depends on many, many factors.
Thank you. So we have a comment from Leo. Leo, did you want me to read your comment, or if you want to go ahead, please feel free to unmute yourself and chime in. Otherwise, if I don't hear from you, I will go ahead and read your comment.
Can you hear me okay?
Yeah, please go ahead.
Sure, okay. Yeah, sorry for the long message. Our mother is still living independently with daily PSW support. We're trying our best to respect our mother's wishes to live independently as long as possible. We increase PSW support as needed, and my brothers and sisters all take turns visiting our mother to ensure she has in-person visits each day, which we understand is really important for her and for the obvious reasons. I'm fortunate to have 5 brothers and sisters. I can't imagine what this would be like if it was just me. When I visit my mother for longer stays, this enables me to spend quality time with her, but also importantly, so that I can observe her 24/7, which gives me a much better idea of where she's at in terms of her daily behaviors and whether she's declined further. Recently, she woke up one morning and walked past me without a top on, and despite trying to hide my surprise, she said without missing a beat, "It's nothing you haven't seen before," with a smile on her face. This just happened this past weekend, so I suspect she's starting to lose her inhibitions. I will keep a journal as per your recommendation.
Thank you for sharing that, Leo.
Yeah,
it's not easy. It's not easy as a child to see these things, and thank you for sharing that with us. I know with my parents, my father actually is not with us anymore, but it was always very important for me to protect his dignity. And I remember, being careful to cover him in terms of hygiene or anything, like if I was around and he would be exposed. And then in the later years, similarly, he said to me, "Oh, don't worry about it. I don't care." So it is that loss of inhibition that sometimes can be shocking. Lucy, did you want to add anything?
Yes, no, I mean, it's amazing what your family is doing for your mother. It's really commendable. And the fact that she was so, non-blasé about it, it's not something, I haven't seen anything. And you being a son, it's really, it's difficult. And I could understand you having to deal with that. And so just a little tip that might, if it happens again, you could just say to your mother, it's a little bit cool in the house. Why don't we put something on or something like that, or a shawl? But just recognizing that things are progressing. So I just want to thank you for sharing with us.
I think Leo wanted to add something. I saw that pop up.
Yeah, sure. Just one quick thing. Yes, thank you. I think that was the reason why I was wondering earlier on at the outset whether or not the losing inhibitions was a precursor to other behaviors, and as you've noted, that it surely is. So it's something that we'll be monitoring for sure. One thing that I wanted to quickly share, really, really quickly, is just something. First, you helped our family with the ethical considerations of whether or not, to put our mother in a home, in one of the caring conversations. And of course, the ethical aspects of it really is something that we didn't really consider. Like we kept thinking, oh no, what we should be doing is what's best for our mother in terms of our point of view. But when you raised those conversations in one of these presentations, it really, really helped us reframe the whole conversation. And my family members and I, when I brought it back to them, we discussed this. And of course, we talked to our mother about it, and she wanted to stay in her home. And so we've tried our best to support her. And she's still living, assisted living, but in her own apartment. So thank you for that. But what I wanted to add was we have added all these elements to help our mothers to age in place, to stay in her home. And I wanted to share this with everyone here. And I thought that maybe you could have a caring conversation about using technology to help your parent remain in their home as long as is possible. We use, for instance, Family Wall, which is an application where all of my family members can schedule our turns to visit our mother, for PSW support, for everyone to know, to be on the same page about when grocery deliveries are arriving. Any comments about behavior is logged in Family Wall. It's just an application that's really, really helpful. Another thing that we do, we use Wise cameras. And I chose these cameras in particular. Of course, we put them in just common areas in her kitchen to make sure we can view her remotely eating. To confirm it, our mother will say, oh, I've eaten, and she hadn't eaten. And so we observe that. But the great thing about these Wise cameras, one of the cameras has a privacy feature, and the camera just turns downward. So it doesn't look like a camera. It just goes right down. So we only turn those on when we need to confirm that she's eaten, or to check in with her periodically. But to respect, her dignity and her privacy, we turn those to the privacy mode when we don't need that. Another thing that we're doing is, Google Nest Hub, for instance, using the Nest Hub has been so amazing because it's stationary and it can sit on a tray that she turns, that attaches to her sofa. And when we do video calls with her, it's really, really easy for us to have video calls with her. She doesn't have to pick up her phone and fiddle around with it. It's stationary. All she has to do is touch a little button to accept the call. So the Google Nest Hub has been incredible. And one final thing, an Aura digital frame. These frames are amazing because we can share with our mother things that are happening to us in real time and push those images to this digital frame that's right near her, where she sits typically during the day. And so from wherever we are in the world, wherever we are at that point in time, we can constantly share with her images of her family from the past, present. And so these are just various things that we've been doing, and it's really been helping our mother. And I wanted to share that with everyone, and I'll leave it at that. Thanks.
Thank you, thank you, thank you so much. You've helped us as well, and I'm sure you've helped others in the audience. Thank you. This is what this is all about. That's what this is all about.
Yeah. Exactly. I was going to say, Leo, I just want to repeat also what an extraordinary, besides family and what you've done, how current, how cutting edge. I feel like we need to interview you on a future episode. But I know Diane put something in the chat about, maybe you just want to share that, Diane, about this topic.
Yes, so we had on our McGill Cares webcast, we had Ron Bellino who talked about different technology and tools. So I put the YouTube link in the chat if anyone wants to watch that. You might enjoy watching that, Leo, although it sounds like you have a good handle on different great tools. And I also just wanted to say, I also use the Aura camera just to get pictures of my grandson. And it is a great tool for families to share photos. So I love that tool. Thank you.
So Diane, I know we're at the time. Do you want to make the switch? Maybe we'll switch over to our more private function.
Yes, absolutely. Absolutely. So I'll just say a few words. So thank you so much. Joanne and Lucy, and everyone who's participating from home or work. This part of the Caring Conversations has been recorded and it's going to be posted on our website. So I did post a link in the chat. Our next Caring Conversations episode is Caring for Someone with Dementia, What You Need to Know About Hallucinations, Delusions, and Paranoia. So that will be at 10 a.m. on Tuesday, November 28th. We'll be sharing that information in our newsletter with more information. So we'd also like to gather your feedback regarding Caring Conversations. So my colleague Maria did include a short link in the chat if you'd like to fill it out. Otherwise, we will be emailing that link to you as well. So we'd like to acknowledge that Caring Conversations is supported by Petro-Canada Caremakers Foundation, and it's a project of the McGill Dementia Education Program, which is funded entirely by private donations. If you'd like to join our mailing list to be noticed about important programs and resources, please go on our website or email us at dementia@mcgill.ca. We hope that you found today's conversation useful. And now what we're going to do is we're going to turn the recording off and have a more private caring conversation for anyone who would like to stay and continue the talk. Thank you.